Spondylarthrosis, disc herniation, cervical vertebral instability, and Cauda equina syndrome. Right, so the first condition we'll be looking at is spondylosis, and it's very common. So it's important to know the correct terminology in this case and not confuse it with the condition spondylitis. And this we'll cover a little bit later under inflammatory conditions. The spondylosis is also known as spondylosis deformans, and it consists of osseous proliferation or enthesopathy at the margins of the end plate. So this new bone forms due to metaplasia of the attachments of the annulus fibrosus to the end plates. So it's not the same as osteophytes. Osteophytes occur at osteochondral junctions of synovial joints, and the intervertebral attachment or the intervertebral disc attachment is not a joint. So spondylosis is seen as bony spurs ventrally on the adjacent vertebra, for example in the schematic diagram here. And it's broken down into various degrees, all the way from grade 1 up to grade 3. And here we've got another diagram that just depicts the different grades of spondylosis. So in grade 1, the new bone or the enthesophytes occur at the end plate, but they don't extend beyond the vertebral edge on the lateral view. Grade 2, the enlarged new bone or the enthesophytes extend beyond the edge of the end plate, but they don't connect with that of the opposite side, versus in grade 3, we've got bridging enthesophytes between the adjacent vertebrae. In this radiograph, the arrows show variable degrees of spondylosis along the lumbar spine, and the most common sites are typically the caudal thoracic and the cranial lumbar vertebra that are affected. Usually it's a clinically incidental finding, especially in older large breed dogs. So spondylosis can be broken down into either primary or secondary. In primary, it's usually not clinically significant and is considered an incidental finding. The exceptions are if it extends laterally and dorsally in such a manner that it may impinge on the intervertebral foramina, and in that way it may result in nerve root involvement due to compression by the new bone. At the lumbosacral region, it can indicate that there's Cauda equina syndrome present, which we'll get to a little bit later, and boxers tend to be a breed that's overrepresented for severe spondylosis formation. Secondary spondylosis means that there is some sort of a primary pathology and spondylosis occurs secondarily to that. Conditions that can lead to spondylosis include cervical vertebral instability, disc prolapse, discospondylitis, trauma, disc fenestration, i.e. post-surgical, or hemivertebra. So in this image here, you can note the step formation here between L7 and the sacrum, and the sclerosis at the end plates, indicating some sort of subluxation and instability in this area, and thus the spondylosis seen ventrally here is secondary to a primary pathology. We'll discover or look at lumbosacral disease a little bit later. Right, and then on to something that's often confused with spondylosis, but is completely a different pathological entity, is diffuse idiopathic skeletal hyperostosis, or DISH for short. DISH is a systemic disease affecting the axial and appendicular skeleton. Most commonly we see it in the spine, and that's where we'll be focusing. And it consists of ossification of soft tissues. So on this image, one can see all this flowing new bone ventrally to the spine. It's also known as bamboo spine, and it's usually most prominent at the location of the ventral longitudinal ligament, which runs in this area along the ventral vertebral body borders. So here's a table that just demonstrates the difference between DISH and spondylosis. DISH consists of an enthesophytes that affect the ventral longitudinal ligament, whereas spondylosis is enthesophytes that originate from the region adjacent to the ventral end plates and at the attachment of the annulus fibrosus. DISH, by definition, has to affect at least 4 contiguous vertebrae. Some textbooks say 3, whereas spondylosis is restricted to the intervertebral disc junction. It may occur multifocally though, but it's not as extensive as DISH. With DISH, there's maintenance of the intervertebral disc width, which means that the discs themselves are not diseased, whereas spondylosis might be associated with narrowing of the disc space and thus intervertebral disc disease. DISH clinically might cause spinal stiffness and pain, whereas spondylosis might be an incidental finding without clinical symptoms. And this is because with DISH, because of this long flowing bone, it may cause clinical signs at the first intervertebral disc space that's not affected because of abnormal stresses placed on the disc space by essentially almost a fused spine, if we can call it that. All right, the next condition we'll be looking at is ossifying pachymeningitis, which is just ossification of the dura mater, as seen as a little white line on this image over here. But rather actually should just be called dural ossification because it's not inflammatory as the word meningitis might imply. It occurs in older large breeds and it's typically not significant. And on radiographs, it appears as a mineralized line lying horizontally in the vertebral canal, and it's best seen over the intervertebral canal, usually ventrally, and over the intervertebral foramina and the intervertebral disc spaces. Because in this region, it is most radiolucent and thus most easy to see. In this image, the white line just indicates schematically where it would occur most commonly, and the arrows will indicate this very faint mineralized line along the floor of the vertebral canal, and that's consistent with the location of the dura mater. All right, so Spondylarthrosis is a term that refers to degenerative joint disease of the vertebral articulation facets or those joints, just as Cox arthrosis is a term that refers to DJD of the hip joints. This occurs in older dogs, also the lumbar area, and it's really uncertain about how significant this condition is at the moment. So in the normal lumbar spine, the joint space is this curved radiolucent area with the facets clearly seen and crisply marginated, whereas in the affected bone, the joint space is obliterated by osteophytic new bone. This is a true joint, so there is an osteochondral junction, and we will have osteophytes thus in this region. In this image here is just again a combination of spondyloarthrosis affecting all of the joints of the spine, and then some spondylosis also seen ventrally, and likely in this patient to be incidental and probably just age-related. All right, now on to a very important section, because this condition is very often seen in private practice and at the hospital. So disc herniation occurs when the intervertebral disc contents will extrude or protrude into the vertebral canal, and this can result in compression of the spinal cord or of the nerve roots. Trauma is one cause of disc herniation, although it's not that common. It's at least not as common as degenerative disc herniation, and there's two types of that. In the chondrodystrophic breed, there is chondroid degeneration of the nucleus pulposus, and that occurs at a young age, usually by about 1 or 2 years in the Dachshund already. And this results in disc extrusion or Hansen type 1 disc disease, which we'll get to on the next slide. Other breeds of dogs, for example, the German Shepherd, are also prone to disc disease, but this occurs in a slightly different form. So they get fibrous degeneration, where the annulus fibrosus will protrude dorsally into the canal, and this is called a Hansen type 2 disc protrusion. The thoracolumbar and C-spine are most commonly affected. This is because in the thoracic region, from about T2 to T10, there is an intercapital ligament that extends across the intervertebral disc space from rib head to rib head, and this provides a bit of extra reinforcement across the floor of the vertebral canal over the disc spaces that decreases the chance of disc herniation in that region. So again, the neurological exam plays a critical role. We need to know exactly where the site is so we can perform our imaging, and excellent quality radiographs are needed to look at the disc spaces for narrowing, to look for subtle mineralization in the vertebral canal, for example. So this slide just depicts the different types of disc extrusions versus protrusion. So in the normal image on the far left, A is the annulus fibrosis, and that's the outer portion of the disc, and that is fibrous. The end depicts the nucleus pulposus, which is very elastic. It's gelatinous with a very high water content, and as it degenerates, it dehydrates and it loses its elasticity. In a type 1 extrusion, or Hansen type 1 extrusion, this is typically seen in chondrodystrophic breeds, where the annulus will tear and the nuclear material, which is often mineralized, escapes into the vertebral canal. It can be an acute onset in clinical signs, and the disc material may migrate, usually cranially, from the disc space. And there may be extensive cord edema and hemorrhage associated with this, and so the lesion might span past the confines of the intervertebral disc space. Whereas with the type 2, this occurs in chondrodystrophic breeds as well as non-chondrodystrophic breeds, for example, the German Shepherd again. Older dogs are more typically affected. It's more protracted clinical signs. The nucleus loses its elasticity. It can change shape. The annulus will partially tear and protrude into the vertebral canal, and the protrusion is characterized by protrusion of the dorsal annulus as well as the dorsal longitudinal ligament into the vertebral canal. And typically it's more localized over the intervertebral disc space. Both types, Hansen 1 and 2, should be considered distinct clinical entities, and they're associated with a different pathophysiology. Treatment options are different, post-op recovery and prognosis after medical or surgical treatment does vary as well, so it's important to try to differentiate. It's important also to know that a mineralized disc just means that it has degenerated. It's dehydrated and it's mineralized. It does not imply that there's a disc herniation present. And in this slide, my little marker shows a very well mineralized oval intervertebral disc with a nucleus, but it's located in position. It's still in its normal position, and there's nothing above it. There's no evidence that any of it has moved into the vertebral canal. And so we can say in this case that there is disc degeneration, but not herniation present. Another concept just to demonstrate on this image while we're here is that if one looks cranially at the intervertebral disc space width, as well as caudally, they look much narrower. And this is because of beam divergence towards the edges of the cassette. So whichever disc space we want to evaluate must be in the center, and then only do we get a true indication of the width of the discs. Anything towards the edges or the periphery will be artificially narrowed. Right, so there's a couple of radiological signs that can be seen with disc herniation, and the first one is the narrowed intervertebral disc space, taking into consideration what I've said on the previous slide about beam divergence. We can also look at the intervertebral foramina to look at the shape. Is the shape maintained, or is it narrowed, or is there superimposition of a mineralized opacity over it? We look at the articulation facets. The joint space there may be narrowed, which is another indication that there has been a protrusion or an extrusion. Mineralized opacities may occur within the vertebral canal. It's not always seen, and you're lucky if you do see it. And in the C-spine, because of the ventrolateral opening of the intervertebral foramina, the oblique views are very helpful here again. And I've included a picture here of an oblique view just to show this nice round radiolucent intervertebral foramina, and the arrow just indicates where one might see mineralized material in the cervical spine if there's been an extrusion. So this example on this next slide just shows clearly that there's intervertebral disc space narrowing. There's also loss of shape of the intervertebral foramina. It doesn't appear to be a horse head anymore, for example, seen adjacently. There is mineralized opacities located superimposed over the intervertebral foramina within the vertebral canal, and also this nice curved radiolucent joint space is narrower than the adjacent one, for example. These are typical findings, but they're not always present. So sometimes one may only have a suspicion that there's disc disease because there's a narrowed intervertebral disc space. The next example demonstrates that there is no visible intervertebral disc space narrowing. However, over the intervertebral foramina, there is some loss of shape. There's some mineralized opacity sitting ventrally over it, and there's also a large mineralized opacity lying within the floor of the vertebral canal. So in this case, the diagnosis is quite easy that there is herniated mineralized disc material. There's also some disc material that's mineralized, that's remnant in its normal position within the region of the disc. And this example here again is a little bit more tricky because the disc space isn't narrowed, but one sees a very nice round mineralized or oval mineralized opacity, and going more dorsally from that, it sort of connects with this mineralized structure that's lying within the floor of the vertebral canal. And that's a nice volcano, almost like appearance of the extruded disc material. We look at a CT image of what this might look like, and this is why CT is so lovely to see these changes, is in a transverse section, there's no superimposition, and we can see the disc material sitting in the intervertebral disc space, just popping up into the vertebral canal and compressing the spinal cord, which is now lying on the left side of the image. All right, now we get to the section on myelography. For DIM 400, you only really need to know the complications of myelography. However, I think it's important, if you understand myelography, you'll really understand the pathology affecting the spine. CT and MRI are expensive, and they really haven't replaced myelography, and it's still a procedure that's widely done in small animal practices, equines, as well as referral hospitals. So just looking at the anatomy cross-sectionally through the spinal cord, the dura mater is on the outside. Deep to this is the arachnoid membrane with the subarachnoid space, which contains CSF, and then the pia mater is fused to the spinal cord. So what happens with myelography is a needle is inserted into the subarachnoid space, contrast is injected, and then it forms a column around the spinal cord, allowing it to be indirectly visualized. So we don't really see the cord itself, we see the effect of a lesion from within the cord or from outside of the contrast column. A myelography is essential to localize lesions. Its indications are for surgery. We need to know where the lesion is so the surgeon knows where to cut. Multiple sites of disc extrusion may occur, and we need to know which one is most severe, so which one is the site that needs to be operated. We need to rule out underlying causes. This might be intervertebral disc disease, there might be a bony malformation, there might be a tumor, and extradural compression is the most common type of compression that we see with intervertebral disc disease. So myelography is performed by first doing survey radiographs. This is to rule out obvious lesions, for example fractures, and get proper exposure factors. Omnipaque or ioxol is a non-ionic, low osmolar iodine-based compound, which is given into the subarachnoid space, either via the lumbar group or the cervical group root, and then lateral VD or DV views and oblique views are taken in all cases. And this can be combined with a dynamic study. A dynamic study are those ventroflex, dorsiflex, or traction views that we mentioned in the first study or in our first lecture. Here is just a lateral view just to show what the myelogram would look like. There dorsally is a very thick contrast column. Ventrally it's slightly thinner, but one can see that it's fairly regular. It narrows slightly over the disc spaces, which is normal, but there's no evidence of pathology. And the spinal cord itself is seen as this filling defect in between the two. Indirectly, we're visualizing the spinal cord. So lumbar myelography, if the patient's head is towards the left in this image, is performed either in lateral or sternal recumbency. And the site where we perform it at is between the L5, L6 vertebral spaces. So the spinous process is palpated, of L6 is palpated just cranially to the ilial wings. The needle is inserted along the cranial edge of the spinous process, parallel to the tabletop and perpendicular to the long axis of the spine. From there, the needle bevel is placed on the floor of the vertebral canal. In this case, if you penetrate the spinal cord, it doesn't really have a clinical effect. And as I've said, L5 to 6 is the space of choice. L6 to 7 can be used as a second choice, and L4 to 5 as a third choice. Here on this slide, we are just demonstrating the correct needle placement for a myelogram, where the bevel is on the floor of the vertebral canal between L5 and L6, and here we are ready to inject. For the cervical route, patient positioning is very important. It's very similar to how one collects CSF. The head is held at right angles to the neck. The skin is penetrated on the median plane, midway to 2/3 way down, between the palpable external occipital crest or protuberance and the wings of C1 or the atlas. Once CSF, the needle is slowly advanced until CSF is obtained, and then one can slowly inject the contrast media. And this is a very delicate procedure because if you penetrate the spinal cord, you can kill the patient. Okay, then just a little bit on the lesion classification, and it will help a lot if one keeps these three compartments in mind. Extradural means that the lesion is outside of the dura mater, for example, outside of the dura mater and between it and the vertebral body or the bony structures. This is typically a tumor, a hematoma, intervertebral disc extrusion would also occur here. And then we'll look at the myelographic appearance on the following slides, but one column will deviate and attenuate, so it will thin. And on the orthogonal view, the contrast columns will look like the cord is widening. And if it's an annular or circumferential lesion, it'll look like an hourglass appearance. An intradural extramedullary lesion means that it's outside of the parenchyma of the cord, but confined within the dura mater. So it's in this meningeal region. And that's typical of neoplasia to sit there. And then an intradural intramedullary lesion sits within the spinal cord parenchyma. And this would be, for example, inflammatory infectious disease or neoplasia. So these schematic images just show what a myelogram would look like. On a lateral radiograph, if there is a disc protrusion, it will sit ventrally, and then what it will do is it will deviate the contrast column dorsally, and it will thin both columns. Then the ventral column and the dorsal column will be thinned. On a VD radiograph, if the lesion is sitting laterally, it will do the same thing. It will deviate the contrast column axially or inwards, and it will narrow both of them at the site of pathology. On the orthogonal radiograph, so at 90 degrees to any one of these two, so for a lateral, that would be a VD, and for a VD, it would be a lateral. Because it's sitting where we really can't see it with the beam, it will just look like the cord is widened in that area, and the contrast is narrowed from within. Whereas a circumferential lesion that goes all the way around will look like an hourglass and deviate inwards and be thinned. So here's an example of an extradural lesion caused by a disc protrusion. We can't see that this disc is mineralized, and this would be an indication for myelography. Here one can clearly see the column, the ventral column being dorsally displaced or deviated, and the exposure factors aren't great, but it would be thinned as well. And if we would take an orthogonal view of this, so a 90-degree view, which would be a VD in this case, it would just look like the cord is slightly widened at that area. So the complications of myelogram is something that you guys do need to know. Seizures can occur, especially via the cervical route. So you want to avoid giving contrast rapidly because this will result in very rapid pressure changes within the subarachnoid space. To prevent this, we try to elevate the head, and if seizures do occur, you can give Valium IV. The clinical signs might be aggravated due to introduction of the ioxol. It may also be aggravated because some flexed, extended, or traction views have been done, or if a myelogram has been performed in a patient with inflammatory or infectious spinal disease, for example, GME. ideally, we don't want to do myelography in those cases. Apnea might occur if you inject too rapidly, and obviously if you puncture the medulla oblongata, then you might have some serious side effects. Here's just another example of a clinical case. On the lateral view, the contrast column is seen over T12 and 13 to just narrow on this view a little bit. Don't really see the pathology, but then we would have done a VD view. VD view may have shown nothing, and then one goes and does oblique views. So in this left oblique, which would be correctly termed a ventral 45 degrees left, dorsal right oblique, we don't see anything in that area. And then we will go and do the opposite oblique view. And this area on the right oblique, or the ventral 45 degrees right, dorsal left oblique, one will see very clear deviation of the contrast column. And so this lesion is located right ventrolaterally within the cord. And a VD and a lateral view is not going to detect this. This is why the oblique views are so important. So don't worry too much about the terminology here. Just understand why myelography is so useful, and understand the anatomical location of the lesion, extradural versus intramedullary versus intradural extramedullary. Right, the next condition we're going to be looking at is Wobbler syndrome. It may be better also to classify this as developmental and not degenerative, but it has some overlap between the two. It's also known as cervical vertebral malformation, malarticulation, or cervical vertebral instability. There's actually many other synonyms also, but stick to one of these two. It occurs typically in large and giant breeds. Young Great Danes are overrepresented. They tend to get osseous malformation, for example, the narrowed canal or malformation of the synovial joints or the articulation processes. So in them, it's maybe more correct to call it developmental, whereas the adult Doberman usually has intervertebral disc protrusion or hypertrophy of the dorsal longitudinal ligament, which will cause compression. They also get vertebral canal stenosis. So one can often get a combination of different pathological features. It can be static or dynamic. Dynamic just means that the compression may worsen or improve depending on the neck position, whether it's flexed or extended or under traction. And typically the C5 to C7 sites are affected, although some dog breeds, especially young, larger breeds, may be cranially as well. So the clinical presentation is typically progressive signs. They start with hind limb ataxia initially. They might have proprioceptive deficits, nail scuffing. Those are the first things that can be noticed. They might resent neck manipulation because it's painful. And then it will progress cranially to include the thoracic limbs, which are typically not as badly affected as the pelvic limbs. And eventually, you may end up with a patient that's quadriplegic. The pathophysiology is multifactorial. It may be overnutrition, but there's definitely a genetic basis if you see certain breeds are more represented than others. The bony changes will be visible on radiographs, whereas soft tissue changes typically require either a myelogram or CT or MRI to visualize. And any dynamic changes will need dynamic views performed additionally. So the typical radiographic views would be a neutral lateral, traction lateral, or dorsiflexion or hyperextension lateral, and a VD view. And these might need to be performed after a myelogram as well, and even with advanced imaging such as CT and MRI, these views might be done with all of the views neutral as well as the dynamic views. Here's an example of a bony change that's quite specific to the Doberman. They might get vertebral body malformation, where the cranioventral margin of the vertebral body is incomplete. There's then loss of support for the disc, and the vertebra might tilt. And as a result, we'll get increased intervertebral joint movement. We might get spondylosis, secondary spondylosis, disc herniation, and also a narrowed intervertebral disc space. This slide just demonstrates the difference between the findings in a normal disc protrusion or extrusion. At the top here, one just sees a normal appearing vertebral body, but there's definitely a collapsed disc space, versus in the Doberman, it appears as if part of this ventral portion of the vertebral body is completely malformed. The intervertebral disc space is abnormal in shape, it's almost wedged, and there is dorsal displacement or subluxation of this vertebral body. And there probably will be intervertebral disc protrusion or extrusion in this case as well. The bony changes typically that one can see might be due to sagittal stenosis, so there's dorsoventral narrowing or a funnel-shaped vertebral canal. Lateral compression of the spinal cord might be due to medially deviating pedicle, or articulation facet malformation, where the joints become, or the facets become very large and malformed, and they then impinge dorsolaterally into the spinal or into the vertebral canal. And this image here is just an example of a medially deviating pedicle. This is a normal pedicle up top here. You can see it's nice and straight, versus the one indicated here where caudally it narrows and it deviates medially. And in this case, a myelogram has been done. One can see the contrast columns outlining the spinal cord. And here, this contrast column is also thinned and it is deviating medially. Some soft tissue changes may occur also in these wobbler dogs. And just a schematic image again to show what happens with ventral compression. This could be from the annulus fibrosus or the dorsal longitudinal ligament that's hypertrophied, and it will from ventrally push up onto the ventral contrast column. Dorsal compression can be by the interarcuate ligament or the ligamentum flavum or the joint capsule, and this will come from dorsally and press ventrally and narrow the contrast column. Just a note on the differences in the types of compression we experience and why we do these special dynamic views. In this neutral view, there is a ventral compression, and we don't know whether this ventral compression is due to a disc protrusion or a hypertrophied dorsal longitudinal ligament. And what happens here with traction is if it improves, in this case, the lesion completely disappears. Now, from this, we can tell whether it is disc material or if it is soft tissue material. If it's a disc, it's unlikely to improve, whether if it's soft tissue hypertrophy, it will improve. And on this next slide, we depict this. In a lateral neutral with both disc herniation or proliferation of the annulus fibrosis or other soft tissues like the dorsal longitudinal ligaments, both will show deviation of the contrast column and thinning of it, where with disc herniation, in traction, it will not improve, whereas with proliferation of any soft tissues, it will improve and essentially go away. And this will help one decide treatment-wise what to do, whether one is going to decompress and remove the tissue or distract and fuse this area. And you guys are referred to surgery for further discussion on treatment. Right, lastly, Cauda equina syndrome is essentially the Cauda equina is a collection of nerve roots that lie within the vertebral canal, caudal to the termination of the spinal cord. And the syndrome is a clinical entity of compression of these nerves. And there's many different causes. And it's often very confusing depending on the text that you read to try to classify this. But essentially, it can be due to canal stenosis, instability of the vertebra, intervertebral disc protrusion or extrusion, trauma or neoplasia. And here flexed and extended lateral views become important. They might demonstrate vertebral displacement and subluxation. And again, these might need myelography or they might need further imaging such as CT myelography or MRI to depict this. So typically these patients present initially with back pain, tail weakness, paresis, and eventually urinary and fecal incompetence. And it's large breed dogs again, especially the German Shepherd, around 6 to 7 years of age. And in this image here, one can clearly see that there's a narrowed intervertebral disc space at L7 to S1. The end plates are sclerotic. There is spondylosis present, which indicates in this patient that there is some sort of instability here. So here we've got Cauda equina syndrome, probably due to a disc protrusion or extrusion in this area. And on this last example, again, one can see at the lumbosacral junction that there's obvious subluxation or step formation between the last lumbar vertebra and the sacrum, again with collapse of the intervertebral disc and secondary spondylosis. So this patient also will have Cauda equina syndrome. And unfortunately, it's very difficult to determine, even with advanced imaging such as MRI, how severely this patient will present. Often dramatic changes on radiographs might not be that clinically significant, or changes that are very subtle may result in a patient that's got extreme clinical signs. All right, so that's the end of this lecture on degenerative conditions. The next section is going to cover a bit of inflammatory and infectious conditions, as well as neoplasia of the spinal cord and the spine in general.